Thank you, Dr. Meenakshi. Good afternoon. I'm speaking to a hall full of ophthalmic educators and I think titans in the field. So this is very basic, something that I'm talking. But thanks, Dr. Meenakshi, for including me in this. One is how to set up a wet lab for residency training. Well, why do we need a wet lab? Like they say in the army, those who sweat more in peace bleed less in war. If you have a wet lab, if you have done your training well, chances of something going wrong are less. And today this has become even more because today residents do not get the opportunity to perform enough number of cataract surgeries to really hone their skills. It's a study we had done about 15 years ago in Pune, in which we had found that the median cataract surgeries that were done in the 12 institutions in and around the city was less than 10 for a 3-year residency. And phacoemulsification or non-cataract surgery was, it was just not covered in many training programs. This is a pan-India study that was done by the ARC-AIOS about a decade ago. And here also, if we see only in manual small incision cataract surgery, and there is a wide range, and if you will look at the mean, for the manual SICS, the median is somewhere around 50. There are huge amount of outliers, and in most of them, the median would be nearing to 0. In fact, half of the residents in Indian residency programs did only one phacoemulsification during their residency. And in most of them, they did not get to do any glaucoma surgery, no trabeculectomy, no strabismus surgery. We can perhaps say, okay, vitrectomy, retinal detachment surgery, refractive surgery, LASIK and all perhaps can be kept for fellowship. A lot of oculoplasty, ocular oncology can be kept for fellowships. But even other than a chalazion and a pterygium and some amount of cataract, it was not there. In fact, when this was compared with doctors who were trained in the last century, the senior lot of doctors like Dr. Grover here, they had perhaps done more surgeries during their residency and immediately after that compared to the newer crop. And if we look at the publications that have come during COVID times, where for almost a year, for 2 years, ophthalmology residents have been put only to COVID duty. Of course, when there is a war, it's not just the soldiers, all the supporting members, the cooks, the cleaners, everyone has to fight. So all of them, yes, did a COVID duty, but then they have set out to become ophthalmologists. What about them? And when will they learn it? This is where wet labs come in. This is a recent publication that had shown that residents who had spent more time in wet labs had lesser complications, had better outcomes after cataract surgery in terms of posterior capsular rents, vitreous loss, aphakia, all of that was less. The visual acuity improved. But most importantly, wet labs gave trainees a space to learn in a risk-free environment. And if there was a particular step of surgery that they found challenging, they could do that step again and again till they honed it. And that also helped enhance their psychomotor skills, hand-eye coordination, which is very, very needed for microsurgery and ambidextrosity. I remember 30 years ago when I learned cataract, we learned it first using the cryo and then with ICC. And if a vitreous would come, well, you could always cut the vitreous and suture it and be done with it. And as long as you didn't really mess things up, your supervisors or your seniors would be quite happy with you. Today, all of you in the room, all of you have residents, you have fellows, and everybody is more anxious or more scared of what their trainees would do because the patients and their relatives and their caregivers have changed hugely in last 30 years. Earlier, if the outcome was not that good, if a patient could see 660 or 636, patients would still be happy, would be grateful. If they would not be grateful, they would perhaps just be grumpy, but it would end at that. Today, patients can sue you, patients can file complaint against you, they can go to your medical superintendent, your dean, raise a ruckus, and cause a headache, not just for the trainee, the resident, but also for everybody up on the hierarchy. And so this is that if somebody is not very good at doing things or is slow, well, he'll learn later or, let things be. The second thing that has happened is our government, in its enthusiasm to have more and more doctors, Earlier, we would have about 150 medical colleges in the country. Today, there are about 350 medical colleges. And this government is planning that by the end of the decade, there will be 700 medical colleges. In Maharashtra, almost now every district hospital has its own residency training program. And many a times, the training program will only have one teacher who will do the training, whatever that is. So because of that, as there is less number of people to supervise, more number of trainees who want to learn, obviously what each trainee gets is getting lesser and lesser. So how will they then become good surgeons? This is where wet labs come in. Because teaching is not equivalent to learning, and as Dr. Garg said, with AI and everything, there is so much of extra knowledge. So what our youngsters have is perhaps knowledge excess, but what they have really is a skill deficit. And this skill is something that can be learned only if they do it themselves. And earlier we were lucky or unlucky enough to have bosses or teachers who would literally, kick us on the shin and at other places so that we learnt it. Now it's not possible to do that with the youngsters. And the residency trainers themselves have so many other demands on their time that they just cannot devote it fully to do it just see that the youngster learns. So this is where wet labs, which are stress-free, risk-free, not just for the trainee, but also for the trainer, where various methods and techniques can be tried. They can be tried repeatedly to improve psychomotor skills, hand-eye coordination, stereoscopic visions, to manage possible complications, and most importantly, to improve self-awareness in the residents, in the trainees, so that we give better outcome to our patients. So this is a publication, again, Dr. Lalit Verma's publication with Deepak, as to how to set up a wet lab, and I'm sure all of you are aware of this. It's there in the institutes, and the the boxes that need to be ticked for it. So the room, the curriculum to build hand-eye coordination, the fixing devices, procuring eyes, preparing eyes. Nowadays we have simulators, as Dr. Akshay will tell about the Help Me See simulator that we has. There are a lot of surgical video viewing sessions, so you can actually see it again and again, and therefore improve it. But the two most important things, I think, that are there is the 9th and the 10th. One is the responsibility and the ownership. If there is a wet lab, somebody has to take a responsibility of that, own that wet lab, and see to it that the trainees definitely do it. See it as something that is going to really help them in the long run. Even if they don't perceive it in that way, well, at least they are still made to undergo it. And some amount of a financial commitment is given to the wet lab. Otherwise, generally, most wet labs are the old microscopes, the phaco machines which don't work well, and instruments which can no more be used in a proper operation theater are now shifted to the wet lab for the residents to use. And then they learn on things which have never been very good, and then, of course, we blame them for not learning it very well. So we've had pigs and goat's eyes to teach phacoemulsifications. I remember we used to teach our residents using the cigarette carton transparent covers or boiled tomato or potato pills to do CCC, the complete circular capsular excess, because that was one of the most difficult steps in cataract surgery. And it's not just for cataract. Bacon has been used in USA for strabismus surgery, or for trabeculectomies, they have used half-cut golden apples. Or in Japan, they have used quail eggs for teaching vitrectomy. So there are so many avenues that are easily available, which are not very expensive, that can be used to teach the youngsters. So these are all wet lab eye substitutes that are there. So we can use, banana peels, we can use animal eyes. And things like suturing can be very easily taught. Even many of the diagnostic tests like applanation tonometry, gonioscopy, which are difficult, which are uncomfortable for the patient and therefore cannot be done again and again, can also be done in a wet lab. So we have these eyeball fixating devices. And here, of course, Procuring the eyes is difficult, but most institutes nowadays have eye banks. And even in the best of eye banks, their use of eyes is never more than about 50 to 60%. Nowadays, of course, most eye banks take only the corneal rim. They don't harvest the entire eye, but well, they can do that. And of course, there are many artificial eyes also that are available. The cost is not much. And this is something which the AIOS also has been doing for the past 7-8 years. The SSTC, the TSTC, they are all wet labs that have been constructed, but they are all temporary wet labs. They are for residents, for youngsters, or people who have gone on a maternity leave or have taken a break from their careers and are coming back. It's good for a temporary hand-holding, but there has to be a permanent facility where people can again go back to. And of course, there is a whole lot on simulators, which we'll hear later. But then simulators are excellent, but then they are expensive. They are not that readily available. So wet labs are a bit wet and, well, not that clean, but they can be an excellent alternative for these simulators. And they are something that can be tried in each and every medical colleges, NGO hospitals, wherever youngsters are being trained. This is residents with poor training gets fewer and fewer cataracts to operate upon, get less opportunity post-residency for fellowships and senior residency and consultancy position, and many of them remain locked in a vicious circle of their skill deficit because they didn't learn well, or I would say they couldn't learn well during their residency. They find it more and more difficult to learn better when they pass out. And many of them end up being just medical ophthalmologists or going on to subspecialties which do not involve a lot of surgery. So we need wet labs because this is something that is very easily available. It's not very high tech, therefore it's not very glamorous, but it can be a bridge to help address this skill deficit which is becoming more and more common in our newer ophthalmology generation. Thank you.
Thank you.